Hello and welcome to part 2 of our chapter 20 video lecture series. Here we're going to discuss the diseases of the anterior pituitary gland now. And we'll start by just discussing hypopituitarism and then we'll get into hyperpituitarism. So when we say hypo, we know that means kind of low, right? Below the amount we need. And pituitarism is referring, of course, to our pituitary gland. So here we have an absence or a failure of the anterior pituitary hormones to be secreted. And it might be just one hormone, it might be a few, or it may be all hormones. And that we call panhypopituitarism. Now, how does one suffer from this? The top two most common reasons is due to a pituitary infarction and space-occupying lesions. So what do we mean by that? Pituitary infarction is when we have a big blood loss or we go into hypovolemic shock. So essentially, we know that our pituitary gland is highly vascular, and we know we've got the portal system here to the anterior pituitary gland, and so we need a lot of blood to flow through here. So in blood loss or hypovolemic shock, we're pulling all this blood away from the pituitary gland. And this could lead to tissue necrosis and edema of the gland, which then can lead to fibrosis, and the gland is not able to produce those hormones. And this can also take place in something known as Sheehan syndrome. And this is when a woman is in that postpartum period and she has blood loss because she had a massive hemorrhage during or after delivery. Now, regarding our space-occupying lesions, this could be due to a pituitary adenoma, which you could see pictured over here, or it could also be an aneurysm that has become enlarged and it's compressing against the pituitary gland. And of course, the pituitary gland lays in that cella turcica. It has nowhere to go. So it is going to kind of put pressure on those blood vessels once again, and the gland isn't going to be able to produce those hormones. Other causes are going to be traumatic brain injury, removal of destruction of the gland, or infections such as meningitis, syphilis, or tuberculosis, or it could be an autoimmune hypophysitis. And there could be many different types of clinical manifestations in having this condition because it really comes down to which hormones are not functioning, which ones are not being produced. And so based on that, you can have a better idea of how to treat it. Essentially, you want to replace that hormone. But we're going to go into detail about each of these hormones in a future video lecture anyway, so we'll touch upon more detail then. Now let's move into hyperpituitarism, and this is when we have a hyper secretion of the hormones, meaning an excessive secretion of them, and it's usually due to a benign, slow-growing pituitary adenoma. Remember that an adenoma is going to be a tumor that's coming from cells from the anterior pituitary gland, so you see one pictured right over here. Now they can be microadenomas, and usually these are hormonally silent. They don't really pose a risk, but the macroadenomas, these are associated with morbidity and mortality. So we have a lot more alterations in hormone secretion, or they start to invade or impinge surrounding structures, causing issues there. Now, the manifestations are going to be related to the tumor growth and hormone hypersecretion and hyposecretion. Basically, what we're saying is that the humoral effects in here, if we have a lot of cell growth, so some hyperplasia, then that's going to cause some hypersecretion of some of the hormone secreting cells in here. But then as the tumor gets bigger, we are putting pressure on other cells. And the ones that are most commonly affected are going to be FSH and LH secreting cells. And so they'll start to have a decline in hormone secretion. We can also see that the tumor can impinge upon the optic chiasm. So this is just a picture showing you the relationship between the optic chiasm and the pituitary gland. And of course, we can have visual disturbances if that is impinged upon. If the hypothalamus is affected, then we're going to see disturbances in the control of wakefulness, thirst, appetite, and temperature. One of the first things we're going to see is that the person will have a headache, will also be fatigued. We may have other signs as well, such as neck pain or stiffness. And if it continues to become larger and it could start infiltrating other cranial nerves, then we're going to start to see some other disturbances as well. So we'll talk about some other hypersecretions of hormones, but we'll focus on the growth hormone first. And the first condition is called acromegaly. And this is when we have a hypersecretion of, yes, the growth hormone, but also insulin like growth factor 1. And it's almost always caused by a GH secreting pituitary adenoma. So this does take time. It's a slowly progressive type of disease, and it can cause the connective tissues to proliferate and increase their cytoplasmic matrix, and that happens in the bone too. So if you remember, this is like a histology slide of spongy bone, and we would just increase the bone matrix in here, and so the bones get larger and larger and heavier. And if it's untreated, we tend to see these people have a decreased life expectancy. Heart disease tends to develop, which is secondary to hypertension, coronary artery disease, things like stroke, diabetes mellitus, and then there could be malignancies due to certain cancers like colon or lung. Now notice that acromegaly is a hypersecretion during adulthood, so we're not going to see just a vertical type of growth. Instead, we'll also see that there is a widened jaw, so much so that their teeth will be spaced apart from one another. They'll have a larger forehead, these larger hands. They'll tend to have more of a barrel chest appearance and can even have overactive sebaceous and sweat glands. So they tend to have increased body odor as well. Now, gigantism is a hypersecretion of the growth hormone in children before their epiphyseal plates have closed. So if you remember at our ends of our long bones, we have a epiphyseal disc that's going to allow the child to grow, or the bone rather, to elongate until that disc completely ossifies, and then the length of that bone is kind of in a fixed state. And so at this point, we're getting so much growth hormone that the bone is continuing to elongate, and so you get really excessively tall people. Some individuals could grow to be 8 or 9 feet tall. Then we have hyposecretion of the growth hormone, which is also known as hypopituitary dwarfism, and this happens in children and is manifested by a failure in growth or stunted growth, like we see pictured there. Oh, and I forgot to reference this picture here, but this is a way that we can get rid of an adenoma. It's that transsphenoidal surgery, or transsphenoidectomy, sometimes it's called. Now, what's interesting is approximately 20% of growth hormone secreting tumors also secrete prolactin. Now, usually prolactin is inhibited, and I'm going to kind of go through the normal anatomy first. And in A&P, we talked about a prolactin inhibiting hormone, and that is also known as dopamine. So dopamine is released in order to inhibit prolactin so that it is not secreted from the anterior pituitary gland. But in the case of someone being pregnant, preparing the body to breastfeed a baby, we are going to have a thyrotropin releasing hormone or a prolactin releasing hormone trigger prolactin to be secreted, and that will go to the breast tissue and cause it to produce milk. Of course, the baby suckling at the breast is signaling to the brain that, hey, we need to make more milk. So that's a positive feedback loop here where we can reinforce the production of prolactin. And one more thing I want to mention here before we step away from this diagram is that the thyrotropin releasing hormone, because it stimulates prolactin secretion, we may see that prolactin is elevated in people with primary hypothyroidism. We're going to talk about hypothyroidism in the next video lecture. So when we produce prolactin unnecessarily, this is called prolactinoma, and it's due to a pituitary tumor, once again, that is secreting prolactin. So sometimes there's certain medications that patients will take that will unintentionally block the effects of dopamine, or maybe they are trying to block the effects of dopamine for a different condition. And it can start to increase the prolactin levels. And these could be things like antipsychotics or antidepressants. And as that tumor grows, we can suppress LH and FSH, which could cause estrogen and progesterone deficiency in women and low testosterone in men. The estrogens can typically increase prolactin concentration by stimulating hyperplasia of the prolactin secreting cells. And the clinical manifestations in females are going to be amenorrhea, galactorrhea, which is non-pubertal milk production, hirsutism, which is excessive hair growth on unexpected areas of their body, and it could lead to osteopenia and osteoporosis. And most of these are in relation to that suppressed estrogen levels. And in males, we're going to see gynecomastia, hypogonadism, and erectile dysfunction.